Welcome future doctors and nurses to our insightful journey into the world of rheumatoid arthritis. Today we discuss etiology, pathophysiology, clinical features, laboratory findings and differential diagnosis of arthritis in great details. Let's get started. Rheumatoid arthritis is a chronic autoimmune disorder primarily affecting the joints, characterized by inflammation, pain, stiffness, and potential joint deformity. It can also involve other organs and systems in the body. Understanding its pathophysiology, clinical features, and how it differs from other types of arthritis is crucial for proper diagnosis and management. Let's see how it affects the world population. In which proportions. Rheumatoid arthritis has a worldwide distribution, affecting 0.5 to 1% of the population, with a female preponderance of 3 to 1. It presents from early childhood to late old age, with the most common age of onset is between 30 and 50 years. How it affects the joints. Glad you asked the question. Let's see how that happens. Unfortunately, the exact cause of rheumatoid arthritis remains unclear, but it is believed to involve a combination of genetic predisposition, environmental factors, and abnormal immune responses. Here's a breakdown of the pathophysiological mechanisms. Immune system dysfunction. In rheumatoid arthritis, the immune system mistakenly attacks the body's own tissues, particularly the synovium, the lining of the joints. This leads to chronic inflammation and damage to the joint structures. Synovial inflammation. Inflammation of the synovium results in the release of pro-inflammatory cytokines, such as tumor necrosis, factor alpha, interleukin-1, and interleukin-6. These cytokines promote further inflammation, leading to the destruction of cartilage and bone within the joint. Pannus formation. The inflamed synovium may proliferate, forming a pannus, which is an abnormal tissue that invades and erodes adjacent cartilage and bone. Cartilage and bone destruction. Over time, the continuous inflammation and pannus formation lead to irreversible damage to the cartilage and bone in the affected joints, causing joint deformity and functional impairment. Clinical features of rheumatoid arthritis. Rheumatoid arthritis typically presents with the following clinical features, although they can vary in severity and progression among individuals. Joint symptoms like symmetrical joint pain and stiffness, often worse in the morning or after periods of inactivity. Swelling, warmth, and tenderness in the affected joints. Joint deformities, such as swan neck deformity, boutonniere deformity, and ulnar deviation. Systemic symptoms like fatigue and malaise, low-grade fever, loss of appetite and weight loss. Extra-articular manifestations like rheumatoid nodules, which manifest as firm lumps under the skin, commonly found over pressure points. Rheumatoid vasculitis, which is inflammation of blood vessels, leading to skin ulcers and nerve damage. Pleuritis and pericarditis, which is inflammation of the lining of the lungs, especially pleura or heart, which is also called as pericardium. Let's see what laboratory findings helps us diagnosis of rheumatoid arthritis. Elevated levels of inflammatory markers, such as C-reactive protein and erythrocyte sedimentation rate. Presence of rheumatoid factor and anticyclic citrullinated peptide antibodies in the blood. How can we differentiate it from other arthritis? Rheumatoid arthritis shares some clinical features with other forms of arthritis, but there are key differences that aid in differentiation. Osteoarthritis. Unlike rheumatoid arthritis, osteoarthritis is primarily a degenerative joint disease rather than an autoimmune condition. Osteoarthritis typically affects weight-bearing joints asymmetrically, while rheumatoid arthritis commonly affects small joints symmetrically. Presence of inflammatory markers and autoantibodies is usually absent in osteoarthritis. Ankylosing spondylitis primarily affects the spine and sacroiliac joints, causing stiffness and limited mobility, whereas rheumatoid arthritis predominantly affects peripheral joints. Ankylosing spondylitis is strongly associated with the human leukocyte antigen B27 genetic marker, which is not a characteristic feature of rheumatoid arthritis. Psoriatic arthritis is associated with psoriasis, a skin condition characterized by red, scaly patches, which is absent in rheumatoid arthritis. Psoriatic arthritis may involve dactylitis, which is a sausage-like swelling of fingers or toes, and nail changes like pitting, which are not typical in rheumatoid arthritis. Finally, rheumatoid arthritis is a complex autoimmune disorder characterized by chronic joint inflammation, which can lead to joint damage and systemic complications if left untreated. Prompt diagnosis and appropriate management are essential to alleviate symptoms, prevent joint destruction, and improve the overall quality of life for individuals living with rheumatoid arthritis. Understanding its pathophysiology, clinical features, and differentiation from other forms of arthritis are crucial steps in achieving this goal.